Okay, I make it 9:30. Good morning, everybody. Let's make a start. Welcome to winter. Last 2 mornings, frosty on the ground. How did that happen? I only just noticed that summer is gone. It doesn't seem right somehow. So we've got a long agenda. So let's get cracking. With apologies this morning from Lynette, from Jackie, and from Karen. We have no declaration of interest that have been received. So let's move to the minutes, and let me ask colleagues first of all if they are happy that they are an accurate record. I'll take silence as agreement. Going, gone. Any items anybody wants to raise that are not covered elsewhere in the agenda? There are no formal matters arising, but there's a chance if anybody's got anything they wanted to pick up. Nope. Okay, thank you. In which case, let's move to agenda item 5 and to feedback from board committees. Can we start with audit, Paresh?
Thanks, Steve. Apologies, the camera is off, just having an issue with the bandwidth. But the audit committee met on the 23rd of September. We had a number of agenda items. The first one was the results of the self-assessment of the EPRR, which was kind of presented to the committee, and it demonstrated that Trust had complied to a substantively compliant standard within the kind of process, which is a significant achievement given the kind of the pandemic and what the Trust has gone through. And the self-assessment was also validated independently by a peer review as well. We had the digital team present an update on the progress they've made in terms of complying with the actions which came out of the internal audit report. We've asked the digital team to come back in the January audit committee to present an update on a number of other action items which are outstanding. We have seen a reduction in the number of tender waivers which we sign off. There is still work in progress, but I think we are seeing a trend which is in the right direction in terms of the number of waivers we are now kind of giving. Won't talk about BAF because that's an agenda item on there, but I think overall, we are in a good shape. We also had an update on the information governance as well, which kind of stated that the work has now started to actually kind of evidence the compliance with the newly issued 21-22 Data Security and Protection Toolkit, and the results of which are due at the end of in June 2022. And we have been assured that there are no issues in terms of complying with those things at the moment. Internal audit also presented some 3 draft reports which are related to the COVID risk assessment, where we were given reasonable assurance. We had overseas recruitment. Again, we were given reasonable assurance by them. And workforce strategy and remote working, we have limited assurance, but there are some action points which the HR team are responding to. So I think that was basically the audit.
Great. Thanks, Paresh. Any questions for Paresh? Okay, let's move on to F&I if we can then, Nikki.
Sure, it's a reasonably comprehensive paper, Steve, so it's probably easiest if we just go to questions.
Yep, happy with that. Miranda.
Thank you. In your discussion of the board assurance framework, I note that you agreed that the executive would consider whether a separate risk relating to the estates team ability to undertake improvements whilst the trust was operating at close to full capacity should be added to the risk register. I just wondered what the outcome of that consideration was.
That's one for the executive team, I think, Steve.
Yes, indeed. Joe, Chris, Damien?
Yeah, Chris is on, but we might need to take that. Oh no, Chris is there.
Yeah, I'm here, Joe. I'm happy to take that. I've not raised a separate one around your question. What we're doing is reviewing each of the critical risks on the risk register at the moment, and then if we think that's a particular consideration, then we'll do it for each individual risk, because we have a number of risks already on that register. So it's not appropriate to all of them, but it may be appropriate, and we review all of those every month anyway.
Thanks, Chris. Damien?
So it's a mixture of good news and linked to, well, capacity is an issue that we'll have to focus on, because we have just heard that we've done quite well out of the H2 capital funding bids. So what clearly we'll have to dedicate some time to making sure that all gets completed in the year to be able to hit the targets. So yeah, just worth flagging that as an issue.
And so that is really good news, and I guess that gives us the opportunity to road test some of the kind of process and control improvements that we're talking about through RSM and other places. Would that be right?
Yeah, I'd agree with that. And Chris and I will be putting a plan together over the next few days to look at how elements that we're going to strengthen. So yes, that definitely will be included.
Great, thank you. Miranda?
Yes, just returning to my specific question, presumably then the F&I committee will formally consider that response to what it had asked for in the first place.
We're waiting to see what Steve responds to that. Yes, I think so, Miranda. I think, Chris, it would be helpful to perhaps consider that in committee. If you could just bring it as an action, response to an action, that'd be really helpful. Thank you.
Thank you.
Great, thank you. Anything else on F&I? Okay, let's move to a strategy with Jackie away. I'm hoping that Richard's on the call and can speak to the item.
I am Steve. Apologies, I've got connectivity issues. I hadn't spotted that strategy was on the committee agenda this morning, so I hadn't prepared anything. I do apologise.
That's all right. But you'd be happy to take any questions about the Stratcom?
Absolutely. The majority of the work, Steve, was covering the clinical strategy, which was the first initial set of strategic questions that we were pulling together from the conversations we'd had with the chiefs and operational leads, and we spent a good amount of time covering off those issues with the non-execs, just framing some of the questions that we're going to shape the clinical strategy that'll be completed by December.
Okay, thanks, Richard. Anybody want to raise anything with Richard? In which case, thank you. Let's move to Q&S.
Thank you, Chair. We've had two meetings since the last board meeting, the last one being on the 16th of September. You will recall that we've kind of reshaped the agenda slightly to reflect the CQC 5 domains. The report is comprehensive, but a couple of things I'd just like to draw out. The Infection Prevention and Control BAF is a really important document to overseeing how we're mitigating infection prevention and control risks. And we will, of course, be keeping a very close eye on that over the coming months as winter hits, as you reminded us. Maternity, we had a full and comprehensive discussion. We had the TIA report. And again, we got reasonable assurance based on that. The two areas of concern remain staffing, medical staffing to cover 7 days a week, but there are mitigations to that. We're considering the quality accounts priorities for next year. I don't know, it always seems to come around so quickly, doesn't it? And we'll be bringing that back to the board at some point in time. We had two interesting conversations around getting it right first time. And I'm delighted to say that that is now progressing well, our actions around getting it right first time, and people are back on site. So visits have been reinstated. So again, a really useful programme of work. We had a good discussion about what we're going to do with excellence in care, and I subsequently have spoken to the executives about the next steps and how we need to look at that in the round of prioritisation in terms of transformation and safer staffing. Just to say, the safer staffing report did cause us some concern because, of course, we've got so much escalation capacity open. So again, that's being reviewed closely through POD and also through quality and safety. And then finally, we've started a programme of work on CQC self-assessments, and we're having that programme come back through the Quality and Safety Committee. So happy to take any questions.
Thanks, Amanda. Let's open that up. Nikki.
Thanks, Steve. So I just had a note around the safer staffing, Amanda, and I just wondered whether that would be a helpful sort of route into understanding the drivers of demand for our escalation areas. So if we can address why some of those escalation areas are open, whether that helps us to understand precisely what staff we need, I guess.
So Jo's got her hand up, Steve, but and I'll come back in after that because we have had continued conversations along that very theme, Nikki, just to understand what our capacity was pre-COVID, what the escalation requirements were in normal periods, and therefore what are the metrics that we would need to look at with safer staffing and also the kind of quality metrics. But I'm sure Jo will have a lot to say on this one.
Jo?
So I have, but I'm not going to do it now, only because I know that colleagues are going to bring it up in their sections through the IPR, but it probably is the crux of the matter, and so you'll probably hear it about 4 or 5 times through the meeting. So I just wonder whether we let colleagues pick that up in the IPR section, but it's the right question.
Thanks, Jo. Anything else for Amanda? Great, thank you, Amanda. Let's move to the back.
Sorry, Steve, may I just ask another one? I apologise, didn't get my hand up quickly enough. The CQC, you mentioned, Amanda, there were a few items that weren't yet resolved. I just wonder if you could give the board a view on the importance of the items that haven't yet been resolved and what the timeline to close them is.
Around the CQC, I'll turn to Vicky because she has the detail of this. This is her bread and butter, I would suggest, Vicky.
Thanks, Amanda. Thanks, Nikki. So there are a number of actions which are really quite old now, but important that we make sure we have evidence and assurance for closure. So they're currently on my desk, all 9 of those at the moment. So I'm going to go through them once again, and then I'm planning to take that back through the quality committee just to make sure that we have properly closed all of those off and that we've closed the loop in terms of assurance. So just to give you assurance that we're not going to close any of those until or unless we're happy that all of the actions have been achieved, or if we need to revisit any of those and re-describe them because so much time has passed, then obviously we'll do that as well, but I'll take something back to the next quality committee.
Great. Thanks, Vicky. Let's move on to the board assurance framework then, Pete.
I'll be quite brief about this because the BAF's gone to all the board subcommittees already, so I think the board members are probably quite well cited on this document. It's worth noting that it hasn't gone to POD this month or last month because that was cancelled. The target ratings for all the areas of the BAF have been reviewed and they've been updated to ensure that they remain realistic and potentially achievable. And the dates for achievement have all been updated as well. The reduction in the amount of capital available to the trust during 2021 has led to an increase in the score for BAF 7 from 12 to 16. And the overall ratings for the other areas of the BAF have been reviewed with the appropriate executive for JO and no one same as the last quarter. Sorry, Josh, am I turning your volume? Sorry, Jo. Is that any better?
I think that is a bit better.
I'll sit a bit closer to the camera. The only other thing to mention is that at F&I, Chris highlighted the risk rating of 16 for BAF8. So the Trust is going to have a 6-facet survey of our estates, which is going to be undertaken quite shortly. And that looks at the condition and the risk associated with the Trust estate, and the outcome of this might lead to the score for that area of the BAF being updated in the next quarter. And we did say that we'd raise that with the board, so just to note that. Otherwise, I'm happy to take any questions, and I'm sure execs will be happy to take any questions in their areas.
Thanks, Pete. Let's open that up. Obviously clear and unambiguous for everyone, Pete. Thank you. Final chance. Going. Gone. Thanks very much, Pete. Joe.
Thank you. Morning, everyone. So I thought I'd just start with a reminder of the priorities for the year. There's an awful lot of work to do, but as a result, we need to prioritise. So I'm just going to remind, really. So I'm going to say no particular order, but the first one is probably the most important for me. So it's supporting the health and wellbeing of staff and taking action on recruitment and retention. The recovery of services and building on the lessons learned during the pandemic with a focus on transformation. Achieving key access standards for our emergency departments and cancer. Delivering our financial position and driving efficiencies. Playing a proactive role in the ICS, so the Sussex Integrated Care System, but also place and our role within our East Sussex planning. And focusing on local health outcomes and addressing inequalities, and of course maintaining a safe and high standard of care whilst we continue to meet the needs of COVID. So that's where we're trying to focus our efforts at the moment, recognising that there's a number of other things that we want to and need to do. So I thought just a few key risks, but I'll expand on some of them as will colleagues as we go through the IPR. So the short planning cycles we've talked about before. Does make gives a level of uncertainty to the organisation, and I'll come on to an example of that in a minute. But it does mean that we're planning really sort of at last minute for the next 6 months. This has been alluded to already, and you will hear it, I think, probably at least 3 or 4 other times. Is the sustained demand at the front door and the high bed occupancy. Which obviously leads on to the requirement for additional capacity to be open. Ongoing pandemic and potential flow issues that we just talked about, and I've written flow, but actually I meant flu. The leadership capacity to cover the range of priorities. I'm happy to talk through this a little bit later in part 2 as well, to just give you some more examples. But we are asking our leaders to do a significant amount of work. It's not just recovery, it is focusing on moving forwards at the same time. I don't think we should underestimate that whilst we're continuing to deliver our sort of day-to-day services. And then the loss of COVID funding that we're just trying to work through the impact of that. So in terms of planning and activity, so it continues to be a really busy month for the Trust in terms of activity, and Tara will talk through that a little bit more later. And we obviously continue to plan and develop our services. So the last couple of weeks, we've had the guidance for H2. So this is the second half of the year, which is October to March, bearing in mind we're already in October. And broadly, that covers the financial settlements and the expectations around operational delivery. So the team are working really hard to rapidly review what that means. And we've needed to, or we have submitted trajectories, and Tara will cover some of this a bit later, and probably have a separate session on it because it's reasonably complex. But we've been submitting trajectories through to the year end. And we have submitted a bid against the Targeted Recovery Fund, which Damien's alluded to already. So just in terms of timescales, that's often days or a week or so to do that sort of work. It's not multiple weeks or months that we would normally have in a business planning cycle. A phone call last night confirmed that we had received, or we will receive, the bids that we put in for the Targeted Recovery Fund. We'll share that in due course. We just need to get that in writing and be absolutely clear what the expectations are against that. But it is, no doubt, it is absolutely fantastic news in terms of revenue and capital to be able to support the next 6 months, and some of that will go in beyond that as well. But we also need to factor that into the plans that we've just submitted, so we may need to do a refresh of some of our finance and activity plans. You'll see when we come to the IPR that we're generally delivering at mid or upper quartile. Our aim, as I'm sure everyone remembers, is that we want to be upper quartile across the board. But I think it's fair to say, and Tara will allude to some or cover some of it later, there are some areas when we are under significant pressure, and we'll talk through what those actions are. It specifically is the additional activity at the front door, coupled with the increase in discharge, patients being ready to be discharged onto onward care. That has had a knock-on on our elective activity in some cases, and I think we've at least said 3 times already, we have got additional wards open to compensate for infection control and for the additional activity coming through our front door. So that's an extra ward at Conquest and 3 extra at Eastbourne, and I know Steve and probably Vicky will pick up what that means from a staffing perspective, and Damien no doubt will pick up what it means from a financial perspective. So that one factor does affect multiple things, as Nikki's already said as well. We held a workshop with clinical leaders across East Sussex a few weeks ago to think about how we might deliver urgent care better. We recognise that all providers are seeing a lot of demand in terms of urgent care. And we have put a new UTC model together that we are hopeful we're just waiting for the confirmation, but we hope that that's within the bid and we'll be able to start recruiting so that we can strengthen our urgent treatment centre capacity, recognising that actually that's where a lot of the shift in activity has been. The operational and clinical teams and system partners have been working hard on the winter plan, and Tara's going to cover that a little bit later. We've also submitted a bid for the community diagnostic hubs to be in the Bexhill area, and the aim is to expand diagnostic capacity, specifically radiology and echocardiograms, and we've already increased our endoscopy capacity. Sometimes we don't always cover community as much as we would like to, and that very much is because the recovery from the national perspective has been focused on elective in the main, and then to some extent driving discussions around urgent care. There is a new regional reimagining community services programme just starting. We'll be representing at that regional board, which is great, and on some of the work streams. And it's great, really, I think, to be able to focus a bit more on our community services as well, because they are seeing a change in demand and equally feeling the pressure and the change in patient profile to some extent than we saw previously. I think Damien might put this up in his section. We have bid, and I'm not quite sure if we've got the confirmation yet, but again, to expand our rapid community response teams and to support care in care homes as well. So it's system roles as well as ESHT specifically. I just wanted, because we don't always talk about capital in terms of sharing some of the schemes, although we've done that outside of full board. So our plans for this year is an expanded A&E at Conquest that is open or virtually open and will be operational and absolutely brilliant. So for non-exec colleagues or execs, if you haven't been around it, please pop round. It's beautiful, I have to say, and makes the department significantly bigger to accommodate some of the additional patients coming through. There's an extension at Eastbourne planned for to the end of this year as well. Plans for both of our critical care units, partly to expand and partly to make some improvements so we can better section off our COVID positive and non-COVID patients as well. There are schemes in place already to segregate that, but just to make it a bit more sustainable going forwards. We've got a new ultrasound area at Eastbourne, which allows us to improve the pathway for breast patients and reduce the number of appointments. So it's a triple breast appointment. We're just currently in the process of putting additional capacity into our paediatric outpatients at Eastbourne, which is in the EME, to the end of the exec corridor, and a new facility at Edgerton Road in the Bexhill Hastings area. And I'm super excited about this. By the end of March, we will have, we're aiming to have our dedicated day surgery unit open at Eastbourne, which will also protect our electives and allow us to put more day surgery patients through. And I think that's a bit of a game changer for us, and hopefully will give some confidence to our clinicians as well. And some work on our respiratory wards at both Hastings and Conquest to better segregate, make better use of the capacity we've got on both wards, recognising that sometimes we want to have COVID patients and non-COVID, whereas at the moment we only have all COVID or non-COVID on that ward. So it's some better space, better use of the beds. So Chris and his team have got quite a lot of work to do this year. He's smiling. I think that's a smile. I'm not sure it is a smile, actually. Just keep nodding, Chris. Chris, Vicky and I had a really great walkabout at Eastbourne last week, and we're about to do the same at Conquest in our community sites. We walked around every single clinical area, had a good look for ourselves against the risk register to help us prioritise for next year, but also it was a really good opportunity to chat to all the staff in the clinical areas. It took all day, slightly tiring, but absolutely fantastic. Nearly there. I want to take the opportunity to thank staff again, and I'll always take an opportunity when I can. I think in that walkabout and every time that execs go out, we're all buddied up with wards and clinical areas, although we visit non-clinical spaces as well, as I know the non-execs do as well. It was great just to see how dedicated everybody remains and positive, and people are really wanting to deliver the best for their patients. And so a credit to all of our teams. I want to just reiterate that if I can. A couple of other things. Steve and I went to visit the new nursery the other day at Conquest, which is absolutely beautiful and great for our children and our care providers looking after those children. And those children are the children of some of our colleagues that work in the trust. So that will be opening soon, and I'm going to visit them at Christmas. Hopefully do some sticking and gluing and whatever else happens in nurseries at Christmas. And at Eastbourne, I'm going to the Ugly Bug Ball in a few weeks' time. So hopefully that will be a bit of fun. And last bit from me is just, I just want to name 3 individual members of staff if I can. So many of you will know Simon Perkis, who was our head of comms with the trust, and prior to the merger, been with us for 28 years. He has just retired along with his wife, Jane Perkis, who is, or what should I say, head of nursing in our community services. We wish them well. They'll be sorely missed, but I just wanted to do a massive thank you to them. They probably won't hear me, but everybody else will, hopefully. And I also want to say Janet Garrod, who's Access and Bookings Coordinator in Radiology. I was absolutely delighted to present her 50-year award, having worked at the Trust. She was a little overwhelmed, I think, when the entire radiology department lined up at Conquest a couple of weeks ago. She's still not retiring, which is fantastic. She supports the breast pathway. And I just want to say a personal thank you to her and make that a little more public, although it was pretty public at the time. So that's me done. Thank you.
Thanks, Joe. What a fantastic way to just end that report. 50 years. Wow, that's really impressive. There was a lot in that, Joe. Lots of good stuff, as well as the sort of pressures and so on. Amanda.
Thank you, Joe. That was really, really helpful to illuminate all those capital schemes and how they're coming to fruition, etc. And of course, the focus on staff, which you started with as your priority. I'd just like to add my thanks, actually. I had the day in Eastbourne on Tuesday of last week. I didn't go to the wards. I went to all the other wonderful places that help us be the hospitals that we are. So I went to pathology, I went to HDSU and other areas that seem to be down in the basement. But wow, what brilliant staff, what brilliant services. And I just want to add my thanks to Josh, who organised the visits for me, but also to all the staff that I met. They were absolutely wonderful. So thank you. The question I had, Joe, really was, and I felt it was really helpful to hear about community services, because as an integrated hospitals trust, that is our really kind of bread and butter stuff. I just wondered how the place developments was going, and so how our community teams are engaged in place conversations, and if there was any kind of anything that you could bring to light there.
Yeah, so I think from an ESHT perspective, we are well established operating at place. We might have fancy names every now and again, and they might change, but as a place, as an East Sussex integrated set of stakeholders and providers, we've been working really well together for the last 5 years. So for us, we're just continuing to progress on that journey. As you know, we've got integrated teams with the local authority in terms of some of our community teams and our health visiting teams. And I will be chatting to the Director of Adult Social Care in a few weeks' time to see what does that look like in the next part of our journey. Richard and I in particular, but other colleagues as well, are very much part of the executive and the wider partnership groups across East Sussex and Sussex, actually. So we're just working on our 5 key programmes for East Sussex at the moment, so that we'll be able to bring updates on the East Sussex developments and priorities. Steve's actually leading workforce conversations, and Steve, you might want to pick up either now or later our conversation around supporting the system and workforce. So Amanda, I think what it might be worth doing, and I know Rich's having some internet issues, so I hope you can, is that we'll actually bring back a bit of an update, perhaps in a few months' time, around the whole East Sussex plan. So we brought to you the East Sussex plan, but it'd be helpful to have an update to turn that into a bit more life, if you're happy with that.
That would be really fantastic, Joe. Thank you.
But Steve, I don't know if you just want to mention about the workforce bit. Sorry.
Just before you do, we need to get the timing such that we know what the priorities and approach is going to be from the new ICS chair and leadership team, don't we? So giving that a little bit of time and then coming back to it around place would be good. Sorry, Steve, to cut across you.
No, that's fine. I was going to suggest I do it in the IPR update because it's sort of integral within the within what I wanted to cover, Chair.
Okay. Was there anything you wanted to add, Richard?
Yes, thanks, Steve. The only thing I was just going to pick up on was to say to Amanda that we are still pushing forward with the anchor work, so helping to shape place through that approach, through that model. We have got a presentation with a chap called Michael Wood, who leads on this from the NHS Conquest, who you may have come across before. So that is something that's still very live, and we're working with all of our partners to see if we can shape East Sussex in that way.
That's not the old Mid Sussex Mike Wood, is it? A different
It
Mike.
may well be, Steve, because he lives in it's not, no? Okay.
Yeah,
he lives in Brighton. He's a local resident.
A different Mike Wood. Okay.
Different Mike Wood.
Okay. And so any other questions for Jo on her report? No. Okay, great. Thanks very much, Jo. All sounds like exciting stuff. Let's move on to the integrated performance report. Vicky and David can kick us off. Quality and safety.
Thank you, Chair. So I will make a start. And as always, happy to stop for questions before I hand over to Dr. Walker to take us through mortality. So in terms of COVID, the numbers of positive patients in the trust remains in the low 30s, and there are still some ongoing challenges in terms of pathways and the need for strict infection prevention and control, and we've talked about that here previously. We have unfortunately seen some acquisitions likely due to some asymptomatic patients, some of whom were unvaccinated, with an initial negative COVID test and then a subsequent positive test, so very likely to be incubating COVID on admission. Unfortunately, staff are also reporting some non-compliance with mask wearing and social distancing by some of our visitors and some patients. This is quite challenging at times for staff and does increase risk in terms of our hierarchy of controls. So just want to thank all of our staff and our patients and the public for all that they have done so far. But again, a plea to them just to help us to continue to follow all of those rules. In terms of Clostridium difficile, unfortunately in August we have seen another slight increase in our hospital onset cases. So the year-to-date limit now is 39 against our self-imposed target of 50. We have seen a slight reduction in September, so I'm hopeful that those numbers will stay lower. On triangulation, there were a number of wards who have had significant workforce challenges, and we have seen some lower ratios and skill mix of registered nurses, with, as Jo says, August being another extremely busy month, and indeed September. Post-infection reviews are underway for all of those cases. And on a more positive note, we'd recently had a visit from our NHS IE infection control colleagues that I had invited in to have a walk around with myself and some of the infection control team. Really supportive visit and largely very positive. So thanks to our IPC colleagues for that. In terms of patient safety, our reporting culture remains very positive and proactive, with 827 of the 856 ESHT incidents relating to either no harm or low harm. So a very positive culture, and indeed better than the national average. In terms of pressure ulcers, just a very slight increase in category 2 damage. It may also be linked to some of the ongoing workforce challenges. In addition, we've had some discussions recently about a review of our acuity and dependency data from our SafeCare system that we've used for some years now. And that does seem to be showing quite a steady increase in the number of more heavily dependent patients, and many of those patients will be at higher risk of malnutrition and falls and pressure damage. And we know that some of those patients are particularly frail, are often confused, with many needing the support of 2 nurses for daily care. So that's something that we're continuing to monitor closely. In terms of experience, we received 34 complaints in August, and no change to the top 3 subjects, which are care, communication, and patient pathways. We do have some concerns about our response times, and that there is still a significant challenge, especially for our divisional teams who are trying very hard to ensure timely responses. But that's against the backdrop of really considerable pressures, and as we've said, significant additional capacity open. So my thanks to them. I know they are trying very hard, and myself and Tara will continue to have discussions about what else we may be able to do to support them with that. Despite all of that, I'm delighted to say that our friends and family test numbers and scores are really very encouraging. we had over 1,740 responses in August for inpatients, A&E and maternity. The inpatient score was 99% of patients recommending us, which is extraordinary, against the July national average of 94. Our A&E score was 89% against the national average of 76, and our maternity score was 99% against a national average of 93%. So really extremely positive and very pleased to see that the highest scoring questions from our FFT surveys relating to patients being treated with kindness and also having their pain well managed. So really lovely feedback to read. A&E has seen a slight drop in their score overall, and that was just 16 negative responses out of the 208 for August. And unfortunately, most of that due to waiting times, and we know that they have been under quite considerable pressure. Tiny drop in maternity was just 1 negative response out of their 40 due to pain relief. And delighted that outpatient scores are extremely positive overall, and I know that the team have been doing a huge amount of work, and we've talked about that in the quality committee. Finally, just moving on to workforce, and I know Tara and Steve will also pick this up, but August and indeed September have continued to prove very challenging in terms of workforce demand, and Bill has already mentioned our 3 extra wards open on our Eastbourne site and the extra area open at the Conquest site. Fill rates for nursing, including our care hours per patient day, did drop again, and staffing has been very stretched in supporting those additional areas, and skill mix and registered nurse ratios have unfortunately been impacted, but our senior nursing and operational teams continuing to work very hard and closely together on a daily basis to maintain safety and of course ensure that we have as much support for our staff in place as we can. Chair, I'll stop there for any questions before I hand over to Dr. Walker to talk about mortality.
Nikki, sorry.
Just to help me understand these figures, looking at the care hours per patient day, which escalation areas were open in May? Were any of them open or not?
Yes, they will have been. I had a momentary pause because it's actually the additional escalation capacity in normal times until recently is not unusual, and many organisations, including us, will open and close additional capacity as we need to. And that can change on a daily basis or even within the day as to how many additional beds are open and the impact on staffing. That makes it incredibly difficult to capture things like care hours per patient day. So routinely, or indeed fill rates, so routinely, because it's quite transient and usually the number of extra beds open is quite small, we don't capture that and we don't report on it because it usually is very small. Unfortunately, as we know, over the last few months now, we have effectively had that capacity fully open all of the time. So that's why you can see that red line included to kind of demonstrate the fill rate and the additional impact of those extra areas. But it's very difficult when you have kind of transient additional capacity that opens and closes, and the calculations and the national reporting tools are quite specific. I don't know if that's helpful.
Okay, I think maybe it might be just worth thinking about whether there is anything useful in this information that we might be able to look at. I'm just thinking about some of the conversations we have in F&I around requests for additional staffing and trying to understand how the staffing levels have changed in the last 18 months and impact on safety, just so that those conversations can perhaps be better informed, whether we can use some of that data to help us understand what's going on.
Of course, and I should have said we have included the median, which unfortunately is a few months old, but at least it gives us a kind of a sense of our place in the world, if you like. What I would say is that within that average and within our trust average, there's a huge range per ward, per clinical department, and we have that breakdown. So overall, we can see for August that the average for the trust was 8.67, but there's a huge variety. So if you look at some of our frailty wards, it may well be lower than that. Some of our critical care areas, of course, will be higher. So I've been having discussions with our heads of nursing and associate directors of nursing about looking at that granular detail, because also even ward by ward, there is of course then the split between registered nurse care hours and support worker care hours. Myself and Steve have also recently introduced an additional discussion where, working with the associate directors of nursing and our heads of nursing, we're forward planning and looking at things like our skill mix and some of the challenges that we have, and ensuring that we're making best and most effective use of our staff. And I'm sure Steve will comment on that later in his slides, but I think that's a really helpful discussion, given that it's probably one of our biggest challenges at the moment. So very happy, Nikki, to have a conversation outside of here and see if there's anything that we can do in terms of reporting information.
Thank you, Vicky. I think it would be really helpful to get into, not necessarily get into that detail, but understand some of the complexity, so that when we're sitting there in F&I with a request to approve additional funding, we understand what's driving that request and what perhaps the safety implications are or would be of refusing that request, for example.
Of course.
I think it just might help us. And then this is probably not one to be answered necessarily right now, but I was reading something and it just occurred to me, with our falls, do we look at the stability of the team around the person that had the fall? So whether they are people who are used to working together and have worked together for the last 10 years, is that something we track?
That's a very good question. I don't know that it is something explicitly, but certainly I can take that back to the Falls group. I think there are clearly factors in terms of, as you say, kind of team stability and staff working regularly together. Although I would also say that if you look at some of our very big teams, like our acute medical unit, where you have 55, 60 whole-time equivalents, then actually as a team, because of the shift patterns and the number of staff, you may well have staff who don't work together on a daily basis or indeed regularly. But it's a very good question, and I'll take it back to the Falls group for some further discussion.
Thanks very much, Vicky.
Thanks, Nikki. Amanda?
It was just to build on Nikki's earlier point, and we touched on it before, but I think this is crucial for us to understand in terms of activity, safer staffing levels, money, etc. And particularly when we come on to the later conversation around winter, how are we going to be assured that we've got the right plans in place with the right levels of staffing to provide the quality and safety of care? So as Nikki suggested, I think an offline conversation and bringing something back as part of the winter plan would be really helpful to the board, so that we've got clear sight of that.
Absolutely, and I think the conversations that we've had, Amanda, in the Quality Committee about excellence in care and having a very clear, intuitive quality dashboard is really essential, so that when we're looking at these metrics and we're looking at some of the workforce challenges, we can easily and quickly link those to safety, experience and outcome measures. Absolutely.
Thanks, Amanda. Thanks, Vicky. David, should we move on to talk about mortality?
Thank you, Chair. For those of you following the pack, this is page 17. So if you look at the two graphs on mortality, we track two indices, the SHIMI, the Summary Hospital Mortality Indicator, and also the RAMI, which is the Risk Adjusted Mortality Index. And although they both largely compare us with other trusts in the UK, there are differences in the way that these two are calculated, and I've enumerated many of those in the past, when I think 5 years ago we had a SHIMI of 116 and we were trying to work out why that was. The bad news is that the SHIMI has gone up from 96 to 98 in the last period, but in the same period the RAMI has actually gone down. And looking into this in some depth over the last couple of weeks, I don't think that fundamentally there has been an issue with mortality, and trying to get to the bottom of that has been quite difficult. our overall crude mortality has fallen in this period. So I don't think there's a fundamental issue in terms of more deaths. There are two things which have come out of my investigation. The first is that the increase in mortality largely relates to the Conquest, which has a higher shimmy than Eastbourne, although their RAMIs are almost identical. And when you look at the depth of coding as calculated by CHKS, the depth of coding at Eastbourne, generally speaking, is better than at the Conquest. When you look into that in even more depth, a lot of that relates to palliative care coding, and the amount of palliative care coding at Eastbourne is roughly double that at the Conquest. And interestingly, shimmy includes a change for palliative care codes, which RAMI does not, and that may be why there is a difference between the two indices. So yes, it's disappointing that the shimmy has gone up. We're still below the national average, significantly so. Do I think we have an underlying mortality issue? I don't, because the RAMI is very reassuring. So I'll stop there and take any questions.
Thanks, David. Questions for David? No, that's all very clear. Miranda.
Just to say that this mortality is one of the items that on the balanced scorecard, which is page 52 of 198, RAMI is shown as concern, but the impression that you've given is very much one of assurance about that. So
yeah, Miranda, I'm amused that you spotted that, because I raised this yesterday at exec, and it is a source of constant irritation to me. So the way they calculate whether whether it says concern or whatever relates purely to the current year month's reading compared with the same month last year. So if the same month last year was lower and the current month is higher, then it says concern. The fact that both months were well below the national average mortality doesn't seem to be taken into account in terms of the way that is assessed. And I pointed out how that was inappropriate when we were having a discussion about how that balanced scorecard was developed yesterday. So, for example, one could look at other measures in the balanced scorecard where we are failing completely to meet a target, but because we failed equally a year ago in the same month, it then doesn't flag as concern. And I pointed out that wasn't very sensible either. So I think we need to do some more work on that balanced scorecard to make it more useful for you as non-execs to interpret, and that work is now in hand. But I have no concern about the RAMI, but I do have a bit of concern about the shimmy.
I'm very glad to hear you say that, because actually, I mean, obviously I didn't go through and methodically see what had happened, if you like, month on month, but I did have some other concerns. So I'm very glad the balanced scorecard is being revisited, because I think it is a little bit misleading. I mean, one other area where I picked up where I thought it was a bit misleading was in some of the bits relating to people, where again in Steve's report on people, one gets much greater assurance than one gets from the balanced scorecard. So it's good that it's being looked at. Thank you.
Yeah, and I think the same applies to the access as well. You know, some of the DMO1 and other targets are not flagging appropriately on the balanced scorecard. So I think it's a work in progress, and after our discussion yesterday, I think it will improve.
Joe.
Yeah, I was just going to say I'm happy to have a slightly wider conversation at part two. As David's already alluded to, we spent probably about 2 hours at execs yesterday. I think we're going to change the wording on that, because it is statistically it has changed, but if we moved away from symbols to words, and we're going to try and change those words. Yeah, if you look at the narrative, I probably won't say any more at the moment, just to say it's in hand, as David said.
Okay, thanks very much, David. Shall we move on? Tara, to you.
Yep, good morning, everyone. I'm going to take the IPR as read, and what I wanted to do today was really go through our key areas, give a little overview and the action points that we're taking to improve the position. And some of this links back to the themes that we've had. Struggling to hear me?
So I think it's a connection problem at my end. Apologies, Tara, keep going.
Okay. So I think there's themes there that we've heard already this morning about the additional bids that we've put in. So a lot of this will link through and hopefully start to make some sense. So our emergency department, our front door, we've continued to see the increase in demand, which is plateauing at approximately 10% higher than 1920 activity levels. Our workforce, and they have been absolutely amazing. So again, to reiterate everyone else, is to thank everybody. Next week, I'm going to do a twilight shift in ED to support the teams and really understand a little bit more of what's going on during that latter part of the day and into the night. They haven't experienced the seasonal dips in demand that we would have seen in previous years. It's been consistently high, so that has put some additional pressure on them. But there are additional pressures that we are seeing as well with other elements of our system and our partners on flow. Ambulance attendances are high. We saw 41 ambulances attend one site yesterday morning alone. So we are seeing peaks and troughs in the ambulance demand, and some of that is around their surge levels. And it's also intrinsically linked to our community partners. Bed occupancy is obviously very high at the moment. And again, that is supporting some of the issues that we're seeing with the front door. So what are we doing? We've got a 5-point plan for ED. And this is quite exciting because in line with some of the bids response that we got last night, we'll be moving these forward at pace now. So we're looking at remote consultations for at the front door. So what is that? That is the provision of remote GP consultants. So consultations. So if patients walk in, we can actually review them at the front door, send the patient home and have them have an appointment with a GP. And that is going to be the implementation of Livy, which is a system. So it's a digital solution with remote GP access. So you'll hear the word Livy over the coming weeks, just to put some context around it. Then we're going to look at digital streaming. It's to provide a safe and a consistent approach to streaming. And the solution of that is e-consult. So you'll hear that as well. And the use of e-consult will aim to educate people again at the front door about the right services for their needs. So again, it's so that patients can support NHS 111 online or use a telephone or pinpoint the patients to other areas of health provision. So to preserve ED for those patients that really need that ED support. We want to look at increasing our UTC capacity. And as Joe's mentioned, we submitted as part of the bids an improved UTC, and that's the Urgent Treatment Centre model. And that has been approved. So we're going to look at extending the opening hours. And it's a combination of some of the digital solutions that I've already mentioned, but also for rapid assessment and triage. So that provides a rapid assessment for all ED patients, regardless of mode of arrival, ensuring all patients who continue through the ED process see the full potential of the Urgent Treatment Centre. And then the other thing that we're looking at doing there is expanding the gateway access. So that's any patient that comes through that then is referred on to another specialty, that is moved through the system quite quickly, and that the patients don't remain in ED for a lot of their triage. They will be done by that specialist service provision in the right area within the hospital. So there's a lot going on to support the front door, and it's really a testament as well to our team there, because they have worked really hard following some of the meetings that we've had as a system to ensure that we've got these plans in place, and we've been able to provide assurance that has granted us the money to be able to do this. I'm going to touch briefly on the winter plan here. I know it comes up in the agenda again in a second. So there is the winter plan, and again, I will touch on it in the next section, but there has been a delay in the planning cycle, as we've seen at the moment, and some of that is due to the fact that we have as a system been in OPEL 4, which is our operational escalation level. It's the highest one. So as a result of that, business continuity does say that we should cancel some meetings, etc., etc. So as a system, we are a little bit behind ourselves. So that's why we are talking about the winter plan here, knowing that in the next meeting sequence, it's coming to Quality and Safety Committee and to Senior Leaders Forum. But we have already brought the overall arching cycle to these meetings previously. So there is a high level gap in our overarching winter plan. I will go through it shortly, but what we're going to do and pick up on that is look at how we can, with this bidding process, look at urgent community response work. And we have had the approval that we can increase our 2-hour rapid response provision in the community. And we're also looking at how we can do things slightly differently within the organisation, and looking at our discharge lounges to see whether we can make them 24 hours. What additional support can we put in there? Extended timing from the HIT team, and really look at how our discharge hubs can be linked in with that discharge lounge. So there's, again, a lot of enthusiasm, and it's a real credit to us as an organisation that our staff are still really engaged and looking at different ways of working and coming up with solutions and ideas. So a lot of the stuff that we're including here is coming from the shop floor. So it really is, award to board solutions that we're looking at, which is really great. We've heard a lot about escalation. I would like to change the language, if I may, at this point. Could we call it winter surge wards? Because we know that we are going to have to meet a gap in our bed base for the winter period. So then we will have true escalation over and above that. I know Steve's going to pick it up, so I'm trying to make sure that I don't keep running on a theme, but we do have additional capacity. We will talk about it in the winter plan, but our winter surge wards are open now. To pick up on a point, when we're looking back, we must also acknowledge that with Chris's team, we have been doing some estates work, and ESHT was closed for a period of time. So ESHT moved into Polegate ward. So again, we are also making sure that we continue to do some of the estates work that's needed. For our elective recovery, and I will bring a paper with Damien, I'm sure, in the next board and through the coming meetings, with regards to the new ask for H2, which is the second ask of the second half of the year. It is quite complicated, so I won't go into the multitude of different asks here, but as Joe's alluded to, we have already submitted where we will be for H2. But in the main, for H1, we did achieve our trajectories and also supported the overarching ICS position. Again, credit to our clinicians and all of our teams for the fact that we have had to move sessions between sites to ensure that we maintain activity. And again, going back to the fluctuation of the bed base and that patients have been moved into different areas. But our staff are resilient. And again, I think it is a real credit to them that they are working and moving across different areas. Our H2 seems a change in the operational and planning guidance. And again, I will come back to that at another point. But instead of 95%, which you've heard before, of 1920 activity, the new H2 guidance is that we deliver 89% of 1920 clock stops. And that's a very different language. And I will go through that with Damien, and we will prepare a paper that will be easily understandable, I hope. And we will go through that once we've had the submission finally ratified. But we continue to work through the winter to deliver our H2 recovery. The 5 key areas we're looking at is theatre utilisation. So we're going to continue to monitor and manage our productivity and throughput. And as I've already said, we're looking at moving sessions between sites so that we can maintain the activity. We are working across all of the divisions on the PTL management because we have to, another operational guidance for the H2 period is that our PTL size as of the 30th of September is to be the same PTL size as of the end of March of this year. Now, there is opportunities there that we can look at waiting list initiatives to try and maximise the throughput and ensure that that happens, but that is an area of risk to us, but that is the same for all of the trusts that we've spoken to so far, and it is the same for us as a region. We have, as part of the bids, included the use of digital technology to how we can improve our clinic utilisation. So we're looking at an automation or a bot that can be developed to look at how we actually manage our clinic management. So when a clinic changes its template or its profile, that can be done as an automated route rather than manpower, so that we can ensure that we reduce the number of hospital initiated cancellations because our templates are absolutely accurate, and that we can ensure that we allow our teams to book in chronological order and manage those conversations with patients to ensure that they know that they're coming to the right place at the right time. We've already mentioned the diagnostic capacity. So for the community diagnostic hub, so we are continue to insource for our endoscopy capacity, and we are also just about to go out to procure for echocardiograms, and that will help us support the DMO1 delivery, which again in turn will support the whole pathway for delivery of the electives. The other thing is beds. So we will be looking to ensure that we ring fence the elective capacity to ensure that we maintain our throughput there. And Joe's as well already alluded to the protected day surgery unit as well. I promise I've almost finished. Cancer obviously is another area that is very close to all of our hearts, and we need to ensure that we deliver the 85%. We have been working as a system against our 104-day, over 104-day waits, and we as a trust are the only trust in our region that have delivered against our 104-day target. We are absolutely seen as a really high performer in this area. Although we have missed the 85% target, some of that is around the complexity of the patients that we have at the moment. So we absolutely know our waiting lists, and David Garrett, who's our new ADO for core services, has an absolute grip on that, and we will be working to support him further. So our bigger drivers for the cancer recovery is that we are aiming to reduce the first face-to-face or intervention with a patient to 4 days. So we're currently at 7 days as an average, but some services are have a longer wait. And this will help to support DMO1 delivery, faster diagnostic standard, and the overarching 62 days. We continue to drive the ownership and grip across the divisions and make sure that we're continuing with our cancer weeks, which are really productive and actually something that other trusts are now picking up on, and to maintain our overall PTL size to ensure that we stay where we are, and working with our tertiary partners to see if we can drive waiting times for them down further. Community is the last real area that I will focus on here, and it's sort of community and discharge together. We've seen an increase in our overall number of MRDs, averaging 29 patients above our trajectory, and we are holding around 70 patients per day across the 2 sites as our total MRD numbers. If I looked at the period of time when we were at this report, we were looking at 29 patients above our trajectory, P1s at 14 and P2s at 15 above where we said we were going to be. For the last 5 months, the trust has been averaging to 84 to 89% of patients being discharged on pathway 0. So those are the patients that come in and go home to the same destination. They don't need any further intervention to be able to be discharged home. So we will continue to focus on the reduction in the length of stay between pre-MRD, medically ready for discharge, and those patients that are actually then switched to medically ready. So we will be looking at embedding further our criteria to reside, and those patients that no longer meet the criteria to reside. And we are looking at consultant peer length of stay reviews, and looking at how we can use more digital influencing to be able to report that, and use of Nerve Centre to be able to capture that data more effectively rather than having electronic trackers, for the want of a better term. We're looking at what matters to you. So ensuring as a patient walks through the door, they understand the whole process and the expectations of them and their family in this whole process. So giving them some ownership back, but also that they already have expectations of what day they're going to go home, or likely to go home, what they will need to go home with, and how they will be getting home. It's really important that we do engage not only the patient, but the family as well. So we are aligning our rapid response teams and our discharge to assess beds as well to our processes as much as we can. So with the discharge to assess, that is that we actually, the patient moves into this arena and is assessed by adult social care at that point for their onward move rather than staying in the hospital. And moving forward to the criteria-led discharge, again, we're looking at what we need to do to ensure those patients can go home. Medication processes, engaging with our pharmacy teams to ensure that they are looking at the correct medication and patients' own drugs, so that we are making sure that the patient doesn't feel that they've got a whole new regime, they're staying with where they are. One exciting thing that we're doing as part of winter is our ESHT at home pilot. So we've been doing a test of change on a patient that would be classified ESHT at home. So although the patient is still under our care, they are having that in their home arena. So I do have an example of a 35-year-old female who was discharged home, and we provided twice daily visits, setting up the IV line, and basically providing that section of care at home. And just that one pilot, we have estimated that saved 18 bed days. So these are the little pilots that we've got going on. There's real pockets of excellence that we are working on, and that will support us through winter. And I've already mentioned how we're going to look to expand the discharge lounge. And we are also looking and been working with external companies and providing the care bridge situation that we did last winter. So that's an expansion of our crisis service. So I hope that goes to give you a not so brief summary of all of the work that's going on around all of the different matrix that we're working on operationally at the moment.
Very comprehensive, Tara. Thank you. Questions for Tara? Paresh.
Thanks, Dave. Firstly, Tara, thank you for a very comprehensive update. That's really exciting stuff going on. I had a question, which is not, it's more of a general question. So maybe Joe and Richard can kind of chip in as well. You mentioned a lot of initiatives which are currently underway, like GP Consult. Are those solutions being rolled out in the primary care? I appreciate they are under a lot of pressure, but is primary care rolling out those kind of, so typical GP, will they offer their patients is a levy as a kind of a solution rather than use that?
So Richard's nodding, everyone's putting their hands up. Yes, we are working. The workshop that Joe ran and referred to the other week involved GP forums and the foundation. So yes, we are working as a whole system. It's already, you know, alive in primary care. That's where we've picked it up from. So and again, this is where ESHT is at the forefront. We absolutely picked Livy up and was going to run with it ourselves. We talked to across our system, and then everyone picked that up and said it's a good idea. So it's being rolled out as a Sussex-wide solution. But I'll let Joe come in.
Thanks.
I think you probably covered it in the main, really. Yeah, you probably covered it in the main. I think we are trying to do things. I lead across Sussex for urgent care as the chief exec. That's mean I'm responsible for all of urgent care across Sussex, thank goodness. But we are trying to share where somebody's got good practice. We're trying to have some common models. So where we've looked at our UTC, we know that other organisations are looking at a similar model, just because why would we come up with something different unless there's a specific reason to. I think we've already mentioned Livy. in primary care, and they do have different systems in place. But I probably won't add any more than that. Tara's covered it.
Thanks, Jo. Nikki.
Thanks, Steve. My original question to you, Tara, was going to be, it's been really difficult for a while and you've had some really good initiatives, but we're sort of yet to see a step change in performance. How would that be achieved? And I think you've given me some really good assurance on the front end. So when people are turning up at A&E, rightly or wrongly, I can see some of those initiatives that you're talking about might have that step change that we really need to see. And I think that's really exciting. And I really commend you for that innovation. Where I feel a little bit less comfortable is that flow and discharge point, because I can't hear from what you've said something that would have a step change impact. Is there anything within our gift that we can do to have a real impact there with those medically ready for discharge patients? Or realistically, are we quite reliant on an ICS response and a place and a not ESHT response?
So if I'm honest, Nikki, it's sort of 6 and 1, half a dozen the other. So there are things that we can do for ourselves. And it's really about looking, so if you like, the ESHT at home pilot, so that we can look at how we could still manage our patients, but in their own arena, so have virtual wards, for the want of a better term. I think the other thing is that we are very reliant on working with our system partners, and we do it very well. So we work very closely with our local authority. So I know that the local authority have a significant number of patients that are in the discharge to assess beds waiting for their onward journey, and it's procuring that additional and onward journey support that's needed there. And I'm speaking sort of for my colleagues in the community and in the local authority, but they are experiencing workforce issues at the moment. So recruiting of staff to support that onward piece. So there are things that we can do to support ourselves, and that's making sure that we manage the patient expectation as they're admitted, and start to have those conversations and ensure that we're utilising all of the beds in the system, and we are. We need to do what we can to drive down the length of stay, because that will support the elective flow and the front door, but we are heavily reliant on what the capacity available in the community.
Thanks, Tara. Steve, did you want to add something into that?
Yeah, thanks, Chair. Just building on Tara's point, and I'll come back to it in my report in a moment. Whilst we are reliant on on our partners, there's a number of things we can do with our partners and potentially for our partners to support them, and I'll touch on some of those things in my report. So I think my point is, Nikki, we're not sat here helpless waiting. There's some things that actually, as a member of the system and as one of the biggest members of the system, we can do to help those partners to meet some of those challenges.
Thanks, Steve. Amanda?
So sorry. Yeah, I think this goes back to the earlier conversation, which is how we're working at place, how we work with our partners differently, so that we have a collective winter plan that is based on a shared set of assumptions about flows out of the hospital into the community, and I think that will show us a level of maturity. And I think somewhere along the line it would be really helpful if we could see, and Tara referred to it in her really good report, the levels of bed capacity that we're working out of. Because Tara, you talked about how we do the escalation capacity to build our bed stock, and it would be really good at any one point in time, i.e. every week, what capacity we're working out of, and also what the community has available, so that we're able to see a plan across the system.
Yeah, thanks, Amanda. Tara?
Yeah, so just to quickly come back on that, so the overarching system winter plan, we like I said, we've got a workshop on the 18th to sign off the whole system plan, and then obviously I can make sure that the board has sight of that once it's been finalised. With regard to the overarching bed capacity, obviously we, as ESHT, we have our bed occupancy level, and I'll go through the winter plan in a moment so that you'll see the actual numbers. With regards to the capacity across the whole of the system, we do get an update daily at the operational bed meetings so that we know what beds are available. But it's really that onward piece once it goes further into that sector. So again, I think that's something that will be part of the winter plan. Would it be ready immediately to give you a daily, hourly update? I very much doubt it. But aspirationally, I totally agree. And it'd be lovely if we had a dashboard so that we know we could put patient X into bed Y, and we'd have that available and live. So I'm sure it will come in time, but I'm not sure it'll be ready for this winter.
We're on the same page, Tara. Thank you.
Great, thanks, Tara. I'm going to suggest, in the interest of time, we move on to workforce. Steve.
Thank you, Chair. And once again, I'll take the report as read. I think what I want to do today is really bring together some of the information within the report and the things we've already talked about in a way which hopefully will provide and build on the narrative that we've already discussed around the situation. I want to start by talking about our current workforce base, if that's okay. We've got a good pipeline of recruits coming into the Trust. We've got high levels of interest in joining the Trust continuing, which is good because a number of our partner organisations and other trusts are seeing that sort of post-COVID or that during COVID increase in interest in Outer London trusts sort of decreasing. Our underlying turnover is relatively flat, although it's difficult to see this with a junior doctor rotation this month. And this isn't to say that turnover doesn't remain an area of concern. Of course it does. But the net impact of recruitment and turnover is an increase of in FTEs of about 125 over the last 12 months and 18 in the reported month. In terms of availability within our existing workforce, sickness remains relatively flat, but at a higher level than we'd like it, although the latest data post this report actually shows that this is now reducing. So that, along with the holiday period ending, means we're seeing increased availability of our staff, and we're actually seeing the shape of sickness moving back to a more normal profile of reasons. We touched already on this, but one of the things that many of you will have felt as you've walked around the hospital is the pressure on the nursing staff, including HCAs in the wards. And I do want to spend a moment of time on it, even though we've talked about it already. We've got more nurses and we've got more HCAs than we've ever had before. Our workforce unavailability is dropping, as previously mentioned. Colleagues are still undertaking bank shifts, despite rumblings that this isn't the case. And I think when we look at fill rates, it's easy to assume that actually we're filling less shifts. We're not filling less shifts, we've got more demand. And that's the point, our demand is increasing. As discussed, we've got significant escalation areas. We've got over 70 medically ready to discharge patients who are all high acuity, and this is putting real pressure on us. We've got more staff, but we've got more escalation. So it's therefore really important, I think, from a workforce perspective, that we ask the right question, which is around what's happening to our activity and how we staff it, whilst looking after our amazing people, rather than the question that it's easy to jump to, which is where have all the staff gone and why are they not filling as many shifts? And I want to touch on some of the actions we're taking around that right now. Firstly, we're working really hard to fill the escalation areas through additional recruitment to escalation budgets and pulling our recruitment pipeline forward. And we would expect to see some very early action with that. Secondly, we're putting a real focus on operational excellence. Vicky mentioned this earlier. We're looking at how well we utilise our workforce and maximise their availability. We're supporting the senior nursing teams around holiday rota management, about early roster approvals, around bank booking, around maximising shift planning effectiveness, around avoiding constant movement of staff, and many other things. In fact, Vicky and I are having weekly meetings with nursing leadership colleagues to help support them in these areas and agree any actions that are needed. And I think the really important thing about that is this is genuinely about how we can support them. This isn't a weekly meeting about assurance or whatever else. This is about how can we work together to improve things. Thirdly, and Nikki, I think coming back to your point, or was it Amanda? Sorry, I can't remember. But at a system level, we are working across all of the workforce leads in East Sussex. That's local authority, trusts, community, mental health hospices, and independent care providers, to look at how we can support each other and move people within the system to support its overall needs. So some of the things we're already planning, including ESHT running international recruitment campaigns for St Wilfrid's and St Michael's hospices, and potentially other organisations who don't have the scale to do it themselves but are suffering from workforce challenges. We're expanding the MOU that allows staff movement between organisations to include non-NHS and charitable organisations to help ensure that we've got the right people in the right place. And we're looking at some system level workforce planning and mobility as a result of this. So in other words, we're genuinely, I think, acting as a system and working as a system across all of the providers to say, how can we resolve this? How can we resolve this issue? There's many other points I could make, but I think we've covered a lot of them, probably the majority of them already in the meeting. A small number of points before I finish. Firstly, our COVID vaccination hubs are open again for boosters and are also offering flu. We're running a roving flu campaign in addition. Staff survey is open. Our response rates at the moment are tracking slightly ahead for the time the survey's been open from last year. Mandatory training is frustratingly, well, it's the highest it's ever been recorded at 89.9%. Frustratingly, our target is 90%, and it continues to haunt me that we are so close and not quite getting there. But I think if we consider the pressures that we are under at the moment, actually running at those levels and keeping at those levels is encouraging. Given everything we've talked about today, we're maintaining our real focus on culture, health, and well-being as we continue to recognise the pressures under which, you know, our amazing colleagues are working. And lastly, Joe stole my thunder on it, but we visited the new nursery in Conquest this month. It really is an exciting development, and it's something that, yeah, it really demonstrates. It's another way of demonstrating our support for our staff. It opens in November, and I very much look forward to inviting all of the board members down to see the facility in action. I'll stop there because otherwise, I'm going to be at risk of repeating much of what's been said earlier in the meeting.
Great, thanks very much, Steve. Questions? Okay, if there are no questions, thanks very much, Steve. Great report. Let's move on to finance, Damien.
Thank you, Steve. So we're continuing the position we've been in for the last 4 months. Frankly, in half one, we look relatively secure, and yes, we will achieve break even for the first 6 months. And this is the 5th month that we're declaring up the position. In fact, we've done it with being able to contribute a small contingency into the start of half two. The key issue for us, which we're basing the month 5 report on where we thought H2 would go. It looks like more challenging going into the second half of the year, and I'll follow up in more detail in the second in part 2. But let me just give you a couple of broad headlines. So income, it continues to deliver beyond target. We are still benefiting from ERF, even though the additional contribution is less than it was in the first 2 months in particular, but there's a small additional contribution from this month. So in total, we're 5.6 million ahead on the income line, on the ERF line. The two big costs that we have are staffing increases or staffing costs, which I now have to apparently use winter surge, or even though I'm talking about the first 5 months of the year, for the 3 escalation wards, which at the moment have not been built into the core establishment and therefore are harder to staff and there's less continuity in those wards, and if that's a position we want to correct if we can. It also highlights that we need to finalise our ward establishment and A&E establishment, and I will come back to that at some stage. On the non-pay side, we are seeing some increase in costs, in particular drug costs, which are partly refunded, and partly elements to do with additional activity, in particular diagnostic costs and calling in insourcing can be an increase in that area. We flagged some risks and opportunities, but just before you go on to that, on page 48, we've got the same themes coming through by division. So pressures that we're seeing are really the increases from non-elective care that are coming through on urgent care, medicine and core services. And there is some reliance on agency, but frankly, that's the same position as we've had for the last couple of years. There's been a not quite reaching full establishment. While we've got some success on delivering now our efficiency plan, we still have a target of 10 million, and seeing the pressure that we're facing for H2, we're going to continue to push to try to drive towards that 10 million. That isn't necessarily delivering a pure efficiency. Well, there's also issues of looking at how we can manage cost overruns or cost overspends. And some of those issues were touched on in Tara's paper. So if we can get going on some of the initiatives that we've talked about, so for instance, crisis response or enhanced care in care homes, that has been covered to a degree non-recurrently so far, and we need to basically recruit to those teams so that we're not relying on continuing to do that on an interim basis. In particular, frankly, it's better for the people providing that service because we can provide some assurance that we're committing to this through to March. If I can just go through risks and opportunities. So I've talked about some of the cost pressures we're facing, and I've talked about the benefit that we've had from ERF, and clearly there's a concern that we're unlikely to achieve anywhere near that scale of benefit from ERF in the second 6 months, although I absolutely agree with Tara. We need to understand the move to 89% clock stops and what are the levers we need to push to really drive some higher levels of achievement in that. Sorry, risks and opportunities. I've done the cost side. Sorry, my page has just gone. And in terms of opportunities, that is partly delivering on the programs that we think we're just about to hear. We've had a high level confirmation that funding is going to be agreed, and we will need to kick off those projects as rapidly as possible to make sure they're delivered in year and then get to see some benefit from them. We'll go through some of the areas we think that those will deliver on as soon as we hear about the schemes, but areas like pathology, radiology, and the bids that we've made, particularly on capital, and particularly delivering things like the robot, are useful and supportive in terms of delivering the ERF. And the final opportunity, and I would phrase it as an opportunity, because it's going to provide more security to us and give us a clearer baseline, is we're getting close to finalising the changes to the staffing establishments, and that will provide some reassurance that we can then link to budget and make sure people have a clear baseline about where they're working to. Just in terms of capital, I've clearly highlighted that the capital plan will change slightly on based on getting these additional allocations through. The over planning margin, I'm kind of regret the title because actually that's the normal expectation that some of this activity carries through into 22-23 and is proportionate for the scale of plan we've got. But otherwise we are on track on this. We are, Chris and I, as we've touched on earlier, are working on a set of measures to have more detail in terms of staying on track on this and making sure that the plans are delivered in time for year end. And yes, I'm having reflected on the point that Miranda's made, we'll need to look as a separate risk about how do we manage and how do we quantify the risks of maintaining those capital plans through to year end. Otherwise, can I possibly hand over for questions at that stage?
Great. Thanks, Damien. Questions for Damien? Nikki.
Damien, do you have an update at all anymore on the SIP? I think the number is the same as we saw in F&I. Has it moved at all since then? Sort of informally, if you like.
So it hasn't, but we are developing some schemes. I mean, in particular, I talk about where urgent care has gone. They've actually looked at identifying how they're going to plan some teams in, and also how the UDC is going to work in terms of the balance with A&E. So we've got Paul looking after the division at this stage, and he's actually raised a draft plan, but he hasn't actually put any numbers to it. So I'm expecting some movement by next month.
Thanks, Nikki. Any other questions for Damien? Excellent. Thanks very much then, Damien. So we've had lots of tasters about the winter plan. Tara, do you want to talk us through it?
I feel like I've already done most of it, but yes, we are in winter. As I'd alluded to, as a system, we've been the OPEL 4, which is the operational pressures escalation level. For those, I use OPEL so regularly, I forget really to remind myself what it means. So the original planning cycle is slightly askew, which is why it's coming here and not to the Quality and Safety Committee first. So apologies for that, but we couldn't change the way that the flows of work have been coming through. So I will try and be really succinct on this one, and I think it explains itself if we look at the slide pack that's attached to the report. On page 2, you will see that what we have looked at is our overall bed base, which is our GNA bed base, and that is what we should be using through periods of stability, I suppose is one way of putting it. Not that we've had it for a while. So our basic requirement would be 352 beds on the Eastbourne site and 384 on the Conquest site. What we've then done as part of the planning cycle is add in a number of beds which will support the red and green for the COVID pathways to be able to manage that. And then we've looked at admission growth, and then looking at some of the plans and schemes that have been put in earlier in the year to support discharges ceasing. So we've built in a little bit of a, I suppose, of a buffer into that plan there. So the winter requirement for beds for Eastbourne would be a total of 408, and for Conquest would be 415. So this is where I come on to the use of the winter surge beds. And going on to the next slide, you will see the waterfall there, which shows our core bed number against the winter requirement and then looking at how we're going to start mitigating some of that gap. So we include Devonshire ward that's already open, but we're saying that that now stays open as part of our winter surge. Glynde stays open as part of our winter surge, so they're no longer escalation, they are part of our core winter bed base. And then the crisis response funding, we have put in an additional 4 beds there. We will review that based on the bids that we've just been told are successful to see if that mitigates it anymore. And the bridging service, which for those that remember the end of last year, we called it Care Bridge, in case anyone remembers that terminology. And that is just an increase into our crisis response. So for Eastbourne, once we've done all that, there is a remaining bed gap of 37 beds. So that is where we have to do some of the initiatives that I referred to in my previous report and work very closely with our system partners to see what we can do to increase the throughput of patients in those community beds. It's up to us as well to drive down length of stay, and the BI team are working to see how we can monitor our length of stay within the hospital and the fluctuation of that against the bed requirement that we need for winter. On the Conquest site, we don't have as much elasticity, I suppose, if you like, for increasing the bed base. So our core beds at 368, and then we need to fulfil the bed gap from the 415. And we are utilising Murray Ward. So there are some bays on Murray Ward that up until this point have been, I suppose, empty for the want of a better term, but we are now using those as part of winter surge. And again, looking at the crisis response. The bridging service didn't expand into Conquest as much because we didn't really need it there. So we've tried to align some of the initiatives that way, leaving us a gap of 30 beds at the Conquest site. Now, Polegate, you will realise, is not included in here, so that could be classified as escalation. However, as I've mentioned before, if we are looking to utilise a 24-hour discharge lounge, we would want Polegate to remain as a discharge lounge to enable the throughput and flow of patients. So sometimes we find we're discharging patients later in the day. Some of that is to do with transport, to do with families not being able to receive patients till later in the day. So it's actually looking at that whole profile. So it really, for the gap, it really does require a joined up system working. What I think for me is assuring, and I know it is still a gap, is that when we've looked at our analysis and our system partner, the system analysis from the ICS, we match. So we're very much, our data is aligned and we're very clear of what the gap is. And that's the workshop that we have on the 18th as well, is to start looking at all of the different plans that we've got, that we're putting together, and the proposals that we've put through the bidding process to see whether we can divert some of the anticipated admissions at the front, looking at how many patients we can remove from the hospital into an ESHT at home style ward, and then looking at how we can utilise our discharge lounge and our discharge profile to manage it ourselves. But we have to acknowledge we can't do all of this on our own. This is very much a whole system piece. We can do as much as we can in the acute setting, but we also need to, as we provide the community services as well, look at how we can continue that flow through to the community setting. So there's a lot in there. A lot of it ties into the report and some of the plans and the programs that we've got in place there. But you know, it's going to be difficult, but I think this is the most realistic winter plan that we've got. We're in a much better place than last year, and our gap is recognised by the system, and we are working on how we can do that as a system. And I think that's a really important piece. So the plan is there. And like I say, it's not yet ratified and part of the overarching Sussex system plan. That is to follow. But this is the plan that we have been working on, is recognised by the organisation, is the plan that Steve and Vicky and myself are working on from an establishment point of view, and trying to ensure that the winter surge awards are winter surge and they are staffed accordingly, so that we can make sure that we have substantive staff spread across those wards to support patient care and ensure that we deliver quality and safety, but also the best patient experience possible, and support our workforce, because the last thing that we want, and it's a term that we use, I suppose, is ward safari, that our clinicians know where their patients are going to be, they can manage it accordingly, and that patients aren't moved a multitude of times, because that's not a good patient experience. It's not what we want, and it doesn't go with our IPC guidance either. So it's about making sure that we really, really put the patient at the centre of everything that we're doing this winter.
Great, thank you very much, Tara. As you said, we've touched on this at a number of points in the meeting so far. Questions? Nikki?
Two really quick ones, Steve. Tara, I read your paper to suggest that the length of stay basis, is that 1920s average length of stay that's used to construct this? What's the difference between that and now?
I'd have to sort of, I take it offline maybe with you, Nikki, and go through them on an individual, sort of looking at the P1s and the P2 patients rather than go through it as a whole, because actually that's where it makes a real difference to the patient flow. If I go through, I'll try and give you a brief.
I suppose, Tara, what I'm getting at is not necessarily the precise answer to that question. I was looking at this and thinking, what do I look at this and see as the risks to this model? One, is that length of stay materially different, and does that mean our numbers are not necessarily as accurate as or realistic as they might be? And then the other piece is we started from a baseline where we don't have those 3 wards open, but we do. So that to me is a risk to this as well. We're starting with our 3 winter wards full in September and October. Have we then changed our admission growth to reflect that reality? Or which are we changing, our baseline or our admissions growth? And is that change adequate to reflect our starting position?
So pick up on a couple of those, Nikki, just in response quickly, then I'll let Jo come in. Yes, we have increased our admission growth. Our length of stay hasn't fluctuated too much. Are our numbers realistic? Yes. And I don't think we've ever really come out of winter. I think we need to be, we've talked about this as a system, is really we need to look at a seasonal plan now rather than just saying winter, summer, because winter, according to our ICS plan, finishes on the 19th of April. So we really need to be looking at how we profile that going forward as a system. Our numbers are accurate, they're recognised. I can only go on gut feel in some cases, because obviously things change. But for me, the gut feel on this is right. It really is where we are at the moment. And we do hope that we can shift the dial on some of the other issues that we've got in the community to reduce our length of stay. If we reduce our length of stay, then everything will start to come back together rather than going further apart. But I'll let Jo come in.
Sure.
So a couple of things really. So this is a tried and tested methodology that we developed about 4 years ago. It's, as Tara said, they've added in, or Tara's added in with James, some of the IPC requirements, but it's a pretty tried and tested, and it's pretty accurate, and I'm quite confident in that. We usually go into winter with about a ward short on both sites, and our system plans mitigate that risk. But let's not pretend that that's not a real risk, because it is. And to give absolute assurance that we can close the gap as a system, I think would be naive. So the knock on to that is it affects performance and time in at the front door. A couple of things, and you'll often hear me say this, there's only 2 variables really. It's how many people come in and how long they stay. The demand modelling has been done, as Tara said, on the reality of what's been happening, so that has been increased. In terms of answering the other variable, which is the length of stay, on page 35 of the IPR, or 83 of 198, You can see the non-elective length of stay is tracked, as is the non-elective with the 0 length of stay and the 0 day admissions taken out. We are pretty much, other than the last couple of weeks, we are pretty much where we were in 1920, even with the MRD position as it is. So, and actually our total length of stay is still a little bit better than it was in 1920. So the important thing is to track the two variables of if our length of stay goes up, the risk increases. If our activity goes up beyond the plan, that the risk increases. Likewise, they get mitigated if any of those reduce at all. So hopefully give you some confidence that we've planned for the activity and the length of stay has been consistent. Well, apart from a couple of little blips, you can tell when the peak times were. So it is in there, and you'll be able to get that assurance through that SPC, hopefully.
Thanks, Jo. I think, thinking about what you've just said, I think the only other thing, it's not the variable, but it's the starting point. So if you start with 100 people in hospital, then you add those two things on. But if you start with 150 people in hospital, your numbers will change. So I guess the point I was just asking was that clarification about whether our starting point was all of our beds plus our escalation areas that are currently open, or whether our starting point was our normal beds.
So the starting point isn't anything. The starting point is how many beds do we need at any point in the year. So we don't build it on top of our core. What we say is that activity times length of stay says you need this many beds. So the number that Tara's given is the number of beds we need. We don't add that on to a core, if that makes sense. So the answer is whatever the number was, 400 and something. So
thank you.
Yeah,
that makes sense now. I understand Tara's earlier answer about activity, including it. That's really helpful. Thank you.
Thanks, Nikki. Paresh?
Thanks, Steve. It's a more of a general kind of, from my understanding, is the model actually include the factor in the that there's going to be kind of a surge of flu this year, bearing in mind we didn't actually have the same surge last year? Does that build into the fact that the kind of occurrence is going to be likely to be more severe and more prolonged?
So, Paresh, I'm going to be honest with you here. We haven't had any modelling given to us about flu. It's still an unknown. Right. So we really are looking at, we're basing it on 1920. We understand that we may have to segregate patients, and that's why we included the red and green flow this year. So we have built in a bit of a buffer there for that one. But I suppose this is why we're doing the workshop on the 18th, to just build through or everything to see if there's any more intelligence that's come through to allow us to use that. But usually we base it on what happens in Australia, because we understand and we get a good profile. But they've been locked down, they've been wearing face masks, they've not seen it. So actually that intelligence flow has been quite difficult to track as we go through. So I suppose it's the best that we can deliver at the moment on the intelligence that we have.
All right, thank you.
Thanks, Tara. Amanda?
Thank you, Tara, and everybody. It's as good a model as there is in terms of capacity planning, using demand, etc., etc. But actually, if we count beds, we need to be thinking about our staff, don't we? Because our beds are our staff, and so it's really, how are we, given what we know and given the conversations that we've had, that we have been through, our staff have been through one year that they never really want to repeat. They are tired. We have levels of sickness. We've got real HR workforce issues. And I just wondered, as a board, how we were going to marry these two things, what the thought is around the capacity we need and also our staff. And I would welcome a kind of reflection of how we bring those two things together. And of course, finances is important as well. But for now, let's leave the capacity finances, but let's think about our workforce in all of this. And whilst it's the recognised plan, Tara, I just wondered how Vicky and David were thinking in terms of how their staff are feeling.
So can I just come in there quickly, Amanda, just to say that by establishing our winter surge and establishing some staff rather than trying to do it through bank or anything else, is to provide some continuity of care, continuity of teams. And I think, you know, our workforce are tired of consistent change and moving around, I think is probably a better way of putting it, because we do have a really resilient workforce and we do have some amazing people there, like I say, still coming up with different ideas and really engaged in moving us forward. So as a board and as an executive team, what we're trying to commit to is giving, right, this ward is going to be open. It is part of our winter surge planning, and this is the team that are going to be looking after it. Acknowledging that we will need some temporary workforce to fill gaps now and again, but providing that consistency of team, I think, is one thing that we need to be really working hard to deliver, so that it's that value piece, it's that being part of something and understanding, you know, you're coming onto it, you're coming in today and you're going to work on X ward and you're going to work with so and so, so and so and so and so, rather than the unknown. And I think that's what we're working to do, to ensure that we're providing the right care for our patients, but the right environment for our staff as well. Our workforce are key to this. I can't do my job if I haven't got a fully engaged team. It's, you know, that I cover so many different strands of the organisation. I have to have a really functioning team around me, and I do. They are amazing.
Jo, did you want to come in at this point?
Yeah, I do. And I'm going to probably repeat a little bit of what Tara said. And we spent quite a lot of time at the Exec Away Day talking about this yesterday. And Vicky and Steve have done a lot of work over the last couple of weeks to answer my very simple question, which won't necessarily repeat it, but why does it feel so challenged, if you like, in terms of staffing? And I think it's really important to get the narrative right here. So, and Steve said this earlier, actually, we've got more staff than we've ever had before. Our sickness isn't worse than it was before, and our access to temporary workforce is better than it's been before. So we haven't got less staff. The crux of this comes down to the 4 additional wards that we've got open. And if we can stop, as Tara's just said, pulling people off of the wards that are established to cover the additional wards, which is the right thing to do from a safety perspective, that's why people are frustrated, rather than we haven't got enough staff. So it's really important, I think, that we understand the narrative here. I think Steve, Tara and Damien have, and Vicky will comment, have all said, if our plan now is to recruit into those additional wards, which once we've got those wards established, at least for the winter period, and we'll have to see what demand looks like next year, then actually that mitigates that. So the answer really is, if we can establish those wards, to some extent, all of the rest of it falls away. And that's what we're hearing really quite consistently. So I think it's really important that we all understand the crux of the issue and what the solution is, rather than it necessarily the anecdote that we're hearing. But I know you will want to hear from David and Vicky as well.
Damien's hand was up next. I just want to check whether he wants to.
Steve, can I wait till after David and Vicky, because my point is slightly different from the how our staff feeling point.
Okay, Vicky.
Thanks, Chair. So I'd probably start with the challenge, but then want to finish with an optimistic positivity, I guess. So we've talked about the amount of additional beds that we are needing and wanting to have open, and that is around about 80. I mean, there's we've discussed Polegate as escalation, but so that is it's a lot to staff. There's no doubt that will be a challenge. You know, just for Murray and Devonshire and Glynde, that is over 130 FTEs. and you know, a proportion of registered nurses obviously in healthcare assistants, but large numbers to try and recruit. And I know Steve's teams and the temporary workforce colleagues are working incredibly hard to try and support all of that every day. So that will be a challenge for us, I think, particularly for registered nurses. As Joe says, in the meantime, quite rightly, our substantive areas are supporting those wards and have done so for quite some time. Some of the time we are able to backfill those staff, some of the time we are not. So that will be the pressure that you see and staff feel on the wards, and that is variable in terms of how much of that backfill we're able to cover. So I think it will be a challenge for us, but I think coming back to this winter, I think there is some understandable concern and anxiety from some staff that this winter will be like last winter. My cautious optimism is that it won't. It will be very busy, but it will be different. I don't think we'll see the same levels of COVID that we had. I don't think we'll see the same level of lockdowns that we did. You know, we have a lot of other things in place now, and we'll have those in place this winter that we didn't have last winter. We didn't have our staff doubly vaccinated. We didn't, you know, all of the challenges that we saw last winter, I think we're very specific to last winter. So I think for me, there's a message to our staff to say, yes, it's going to be busy this winter, but it's going to be different. So that's my kind of cautious optimism. But for sure, there's a challenge, Amanda, in the recruitment, and especially for our registered nurses. But I know that we will all work incredibly hard, you know, to try and stabilise all those areas as quickly as we can.
Thanks, Vicky. David?
So I share Vicky's cautious optimism about COVID and this winter. I really don't think it's going to be as bad. I think the government, on the advice of their senior medical officers, have taken us out of lockdown in the summer deliberately, knowing that there would be a surge related to that, particularly in younger people who were not vaccinated. And I think their hope was to get that over and done with before winter hits. And I think that probably, for once, was a good move. And we are seeing that. We're seeing that surge in the 10 to 19-year-olds at the moment, which is driving a lot of the current figures that you see. Flu, as we've already mentioned, is an unknown factor, and you know, we didn't have any flu or any flu deaths last year, and so one might expect at least a doubling of flu levels this year. Just you know, putting a finger in the air, sort of educated guesses where we might be, and obviously that will put some pressure on, and obviously in terms of keeping flu and COVID apart, that does give us an added complexity on the way we run things, and we are making an effort to try and make plans for that, although it's not straightforward. In terms of medical staffing, that there is fatigue, particularly amongst certain groups like the anaesthetists, but they are soldiering on pretty well, and there is a degree of resilience which is being shown by our medical workforce, which isn't reflected in some other hospitals. So I'm proud of them for that. But we do need to keep supporting them, and what you've heard from people like Steve earlier is that in terms of the expanded bed base, we are making a real effort to make sure that it's not just the nursing staffing that we get right for that, but it's the medical staffing, because historically often these wards have been opened in a rush. We've pulled nurses in from bank and from other wards, but actually the junior doctors have just had to spread themselves more thinly, and the consultants spread themselves more thinly. And I think we are making a real effort this year, particularly with the wards having been open for some time and knowing that they're unlikely to close for some months, that we get that medical staffing right. And I think that's a real difference, and I think is a real improvement this year. So a bit of cautious optimism, bit of anxiety over flu, but we are planning to the best of our ability.
Chair, if I may, can I just commend the approach, because I absolutely think that the right focus is in the right way, and establishing teams to run winter beds is absolutely imperative, and just well done. I am feeling very assured that the approach is right and feels very different. So thank you. Doesn't mean it's not going to be difficult, though.
Thanks, Amanda. Damien.
So can I just go back to the funding element of this? I mean, yes, I understand that there's a bit about how do we maintain the staffing, but I think you do actually also need to link the operational plan to the finance. And I think particularly where we've got to on H2, we've had some confirmation around crisis response and some of the extra community elements that we've asked for. I haven't at this stage heard anything about the funding for the 3 wards. So to me, that's step 1 in terms of calling it funded for us as a trust, and I think we still have a bit more work to do to finalise getting this winter plan funded.
Yeah, thanks. Nikki, is that a legacy hand or a new question?
I'm sorry, it's an old hand, Steve.
That's all right. Okay, shall we draw that item to a close? We're running a bit behind time, so I'm going to suggest, if it's all right with you, David, that we take a short break now and then come back in 15 minutes to do agenda item 10.
It's fine, thank you.
Right, thanks everybody. So I'm going to take a bit of a punt and say I think we're all back, even though that's a minute or 2 early. If you're not back, speak up now, otherwise out. Right, let's get going to agenda item 10, learning from deaths. David.
Thank you, Chair. I think you're all used to the format of this report now, but there's some interesting things just to bring out this time. So if people look at the dashboard page, the first thing to say, not surprisingly, there's been a significant increase in deaths in Q4 this year. If you look across the last 3 Q4s, there was quite a peak in 17-18, which was a particularly bad winter with a lot of flu and poor weather, and we had a lot of COPD and deaths from that. We've then had 2 relatively mild winters, and the deaths dropped from 618 to 484 and 499 respectively in Q4 of the last 2 years. But because of COVID and the pandemic, deaths in Q4 this year have shot up to 726. I mean, it's not surprising, but it does just demonstrate quite clearly the impact of the pandemic. The second point to make is the medical examiner system is in place and is working well, and so the number of those deaths that have been reviewed, which is the green line on that graph, now almost identically matches the blue line, and so we are getting a good level of investigation and review of the deaths. And then the third point to just make is in this quarter we have allocated 3 deaths as possibly avoidable, and all those deaths relate to the pandemic in one way or another, not surprisingly. It has proved very difficult to allocate degrees of avoidability to deaths, because really when we're at the height of the pandemic, the situation was one that we had really never experienced before in terms of the volume of COVID patients coming through, the level of staff sickness and the impact that had. And so determining whether deaths were avoidable or not has been quite tricky, but we have allocated 3 as possibly avoidable. So I think I'll stop there and take questions.
Thanks, David. Did anybody else have network problems then, or was that just me? Just me, I can see that. Yeah, okay. Thank you. Thank you, David. Nikki.
Thanks, Steve. David, are you going to talk separately about the learning disabilities deaths?
I wasn't going to. Obviously they're much lower, but the pattern sort of follows the same pattern in that there were, quite a lot more learning disabilities deaths this Q4 than there have been in previous Q4s because of the pandemic. They're all put through an external process, the LADA process of review, which initially was lagging a long way behind, but they have actually made a real effort and they've caught up now. and so the deaths reviewed is almost matching the actual deaths. They've only allocated one as with an avoidability rating, and that was last year, not this year. But I wasn't going to say any more than that, unless you've got any specific questions for me.
Only that you've literally just answered, which was, are we comfortable that is COVID related and nothing else?
The increase is COVID related. There were concerns at the height of the pandemic that some patients with learning disabilities in the NHS were made not for resuscitation, and I've looked very closely at that in our data, and I can't really find a signal that we were making people with learning disabilities inappropriately not for resuscitation. There were some patients with learning difficulties who were not for resuscitation, but they had multiple other comorbidities that made resuscitation impossible for them, but it was never on the basis of learning disabilities alone.
Thank you, David.
Thanks. Any other questions for David? No. Okay, thank you, David. So let's move on to agenda item 11. We've got various reports that are for noting. First, health and safety.
Thank you, Chair. Just here for assurance and information, we've had extensive discussions in the Health and Safety Steering Group and in the Quality Committee. My thanks to Miranda, amongst others, for contributions. And there's nothing particularly I would pick out. Just a huge thank you to all of our staff in the most extraordinary year. And a particular personal thanks to me to Jenny Newbury, our health and safety lead, and in particular her invaluable advice and guidance with COVID risk assessments, both environmental and individual, and of course the infection control team. But huge thanks to all of our staff in terms of all of their ongoing hard work in relation to health and safety.
Great, thanks, Vicky. So that's for there to note, unless there's anything urgent anybody wants to raise. And infection control, again, Vicky.
Indeed, I couldn't think of a more fitting title than A Year Like No Other. That probably says everything I would say, really. But again, huge thanks to all of our teams and our local community and the population for all of their support, which is ongoing. Happy if there's any particular questions.
Yeah, thanks, Vicky. Anything anybody wants to pick up? No. And organ donation, David.
Thank you, Chair. So this report has been written by Judith Highgate, who's one of our intensivists and is our organ donation lead. And just particular thanks to her for doing the report this year, because she's actually on maternity leave and yet is so dedicated she still did the report. It's been a really difficult year for organ donation because of COVID, both because of the added pressure on the intensive care units and therefore the difficulty of dealing with the possibility of organ donation, but also because a lot of the patients that were coming through the intensive cares were unsuitable for organ donation because actually they were infected with COVID. 7 families consented, and that led to 7 organ transplants. The process was well managed. We've received very good support from the specialist nurse for organ donation. From Brighton, we don't have our own specialist nurse because the numbers of transplants are insufficient to warrant that. The only request I noticed, which has crept in at the bottom, which I hadn't spotted, which is probably a bit cheeky to blindside Damien, is we do get some allocation of donor recognition funds depending on the number of patients that we put forward for organ donation. It's relatively small amounts of money and variable depending on how many donations we make. But in order to support larger scale projects within the trust, the committee requests that these funds are routinely rolled over so that we can build up enough funds to actually pay for something significant from them rather than them disappearing. And I think this was discussed with Damien last year, and he kindly agreed to roll them over last year. But there's just a request from Judith that's repeated on an annual basis. But I'll pick that up with Damien offline.
Yes, we'll leave that as an executive conversation outside, unless you want to jump in right now, Damien.
No, well, just a very brief point that while I might have had in previous years some flexibility about year end, I don't think I particularly can sign off transfers between years. I think what we had managed some degree of contingency between years, but I think life's got tougher now. So let's have that conversation as an exec thing separately.
Yeah. Okay. Any questions on organ donation for David? If not, agenda item 12, the use of the trust seal information there for people. And then finally, questions from members of the public.
Steve,
Oh, apologies.
Just on the use of the trust seal, I think one of the we touched on ever so briefly earlier, it was about a new facility somewhere. I just wondered if we could know what it was.
Pete, can you help me out with this while I try and find my bit in the paper?
I can see that Joe's got a hand up. This was for Joe Johnson. If you got anything.
Keep going. You're a bit muffled, but I was going to say community diagnostic hub, but if it's not that, then
it's either sexual health or maternity in Edgerton Park in Bexhill. I'm sure Chris might have the answer. He's got his hand up.
It's Edgerton Park, whatever that is.
Yeah, it's the paediatric community team, Nikki. We're going to be based at Edgerton Park. That's exactly what it's for in Bexhill. That's helpful.
Thank you.
There was some terrible sound on the background there, but I think it's all done now. That's good. Thanks, Chris. Thanks, Nikki. Questions from members of the public. We've had as has become customary, a list of quite detailed questions from Mr. Campbell, and I think we will write to him, and I think you're going to speak to him too, Pete, about how we can get this in such a way that we get the opportunity for questions to be answered at the meeting, rather than a kind of continual dialogue of paperwork between us. We've had a question from Helen Burt, which I would sort of summarise like this. First of all, when will the restrictions on visiting come to an end? Which I think I'll come to you about, Vicky. In fact, let me start with that.
Thanks, Chair, and I'm sure Joe, I think, has already touched on this. We've had some previous questions. I think a couple of things to clarify. So we have never banned visiting at any point, even in the most challenging times of the second surge in winter. We have always maintained compassionate visiting, albeit that's challenging. We keep it under regular review. And it is not the same across the trust. So there are areas where our patients are more vulnerable and we have to be far more careful. And unfortunately, as I'd alluded to earlier, we have seen some acquisitions and we do see some patients or indeed possibly members of the public who are unvaccinated, and not all are happy to be compliant with mask wearing and social distancing. So I think for the moment, certainly we don't have any plans to ease restrictions further over the winter, but we will do everything that we can to be as flexible and as accommodating as we can, and we'll keep that under regular review. We do have virtual visiting, we have devices, mobile devices, and our patients have been using those, but no plans at the moment. But I don't know if Joe has any other comments on that.
No, Joe?
No,
Yeah.
just to support what you've already said, Vicky. I think overridingly, whilst it's frustrating sometimes for relatives, and we need to focus on communication between the ward and the relatives, our overriding priority is to keep our patients and our staff safe. And so I'm with Vicky. I can't see any changes before next spring.
Yeah. The second question, a slightly wider question from Helen. She asks whether the stress and pressure that there has been on NHS staff over the past year or so has affected the quality of care.
Would you like me to?
Yeah, because it's a question that could come to a number of people, couldn't it? But
Sure.
do you want to start, Vicky?
I would say certainly the impact of the second wave, which was very significant for us as an organisation. That given the scale of the impact, I think, and the speed of the impact, that we had at that point a new variant that wasn't known at the time until some weeks after the impact in early December. The vaccination programme was in its infancy in the county, and indeed we hadn't begun our deployment for a few weeks after that. I think the local prevalence at that time in the community was extremely high and one of the highest in the country. So it was hugely challenging. And I think despite everybody's absolute best efforts and every possible mitigation, we redeployed hundreds of staff to frontline services. We closed every service that we possibly could. I absolutely believe that our staff did the very best that they could in just impossibly difficult circumstances. Sadly, I think it was inevitable but unavoidable that there will have been an impact on quality. And I think we've all talked about that as an exec team and as a board. And you know, Joe and I see the feedback from some patients and family members and the complaints, and I think we are all very aware of that and very mindful of the impact that has had, and have offered our genuine apologies for that, and will continue to do so. But I think that staff did the very best that they could. Will that have had an impact on our staff? I suspect it will have, because of course it will not have been to the standard that they will have wanted. But I think we talk a lot about our people and moving forward in a more positive way, and the huge amount of support that we have in place for our staff. But I think, of course, that will have, you know, it's had an impact on all of us in one way or another. But I think we're positive moving forward, and we're seeing the return to a more kind of normal standard, if you like, across the trust. I'm certainly seeing many of the quality indicators recover, thankfully. That's just a personal observation.
Yeah, thanks, Vicky. Joe, anything you wanted to add to that, or Steve, anything?
I think just to give reassurance, I think Vicky's absolutely right, and there was that peak time which was really about the availability of staff, and I think rather than any stress that they will have been feeling, I think the stress was associated with not perhaps being able to give the care, rather than they're not giving the care because they're stressed. I think, you know, part of the metrics that we look through as a board are to give ourselves the assurance around the quality of care. So, but nothing else to add than that.
Okay. Steve, anything from you, or is that?
I just agree with what's said. If the only thing I would ask or answer is, and we've touched on this before, is, you know, we do recognise the challenges that people face. We do know, and Vicky's talked about that. One of the things we've worked very hard to do over the past number of months is to ensure that we're moving the support that is available to the time and place of need. So things like mental health first aiders on the wards. Vicky, and if you've got your badge on today, there we go. One of them right there. And we've got many mental health first aiders. Trim processes. So trauma management process is very close to the ward. So as well as the sort of the more distant telephone type support, you know, really having that time and place of need support, so that if people are a bit wobbly at any point, that, you know, A, it's recognised, and B, it's dealt with as immediately as possible. And I think, you know, things like that not only support that individual, but they support entire teams, just in knowing that that support is there, and that helps with the quality of service, quality of care, which comes through, you know, the amazing resilience that they're able to show.
Yeah, thanks, Steve. Liz, you've got your hand up for a question.
Yes, I just wanted to mention a few things, and then they can be answered sort of particularly. I think support for patients who don't have technology. I'm just concerned that lots of things are going digital, and more and more people are feeling excluded who don't use digital technology. So I wouldn't mind something on that. To do with mental health, about the crisis response beds and those being taken, I'm just a bit concerned with hearing that with Sussex Partnership moving out of the Trust, they're supposed to be having additional beds. I know it's not imminent, but I wouldn't want that to be missed. So all the areas are taken up, and the actual, when there's a desperate need, somebody turning up at the DGH, there's nowhere for them to go. I think definitely staff support have felt supported, but I think also everybody has gone through the crisis together. So I think patients are, and I think the public are, I think in the main supportive, but you've got those that are completely almost irresponsible. And I'm really I apologise for that, because I really feel it's just not acceptable. I'd like to ask if just for assurance that the MLU will remain open throughout winter, and also the maternity hub, if there's anything on that. I think also travel to the hospitals, because obviously we've got a lot of services that are at both hospitals. You know, we've said about the travel between the two hospitals and the necessity for core services. You know, then we have a petrol crisis, and again, you know, when you've got to travel distances, more difficult. And then patient visiting, one visit per day sometimes seems not much, and I know that's the case, but it would be good if it was publicised a bit more, because the amount of people that come to me and say, oh, there's only one visit a day, and that has been the case, but they don't like it, but it is fact. But I was hearing from a pastor who hasn't been able to visit one of his regular attenders because visits are taken up with obviously family and friends. And I wondered what the view was on that, because I actually said to this person, I thought that there would be allowances made. But anyway, I think also positive staff award. That always used to be quite a good bit of the board meeting. Do you not do that anymore? And then a patient story. I think that's really good to have a patient story, whether it's good or bad, if it's not so good and how it was rectified, or if it's good and what was done, because I think that's again something quite nice in the board meeting. Sorry, there's loads of things.
Joe, do you want to start? I think Becky might pick up some of that as well.
So I was luckily scribbling all of that down. So I'm hoping, Liz, we'll do a little check in a minute and see if other colleagues want to come in. So the mental health beds. So to give you assurance, if a patient arrives in one of our hospitals and they require a mental health bed, then the process, as in determined by Sussex Partnership, then they will move into a bed as providing one's available. If they are not safe to leave a place of safety, then we will keep them with us, either in A&E or moving into one of our bedded areas, but usually within the A&E, it depends on the presenting condition of that person. If they have a physical health need, then we will admit them and we'll manage their mental health whilst they're an inpatient. The future plans for Sussex Partnership, as you know, we don't run those beds, is that, well, we would hope that there's enough beds and capacity for them going forwards, but just to give you that assurance that no patient is just left because we haven't got capacity in the system for it. Access for patients non-digital, and Vicky might want to come back on that a little bit, but one of our important things is inequalities, and Richard's leading on that and just currently appointing into an inequalities lead. And one of their priorities will be to make sure that as we innovate and develop our services or continue to provide services as they are, that we are not disadvantaging anybody irrelevant of their age, their background, their demographic, etc. So we would be looking for that as part of our assurance going forwards. Some public are irresponsible. Well, we'll just note that. The only thing, and I would reiterate, is we have talked about having a sort of public and patient charter. So we will promise to provide safe care for you and treat you respectfully, but we would ask patients and public to do the same thing to us. So we talked about that, and so hopefully we'll have some notices up near our front doors. MLU, I can't promise that there is no intention to close it over the winter or indeed at any point in the future. If there is a significant staffing issue, then we will have to take that as a risk assessment at that time. But we have no plans whatsoever to close now or indeed in the future. And the maternity hub will be sitting in our BFF and transformation plan. So we'll talk to you about that in due course, Liz. We're just not quite there on that. Travel to hospitals. I know that Chris has had a conversation with one of our local MPs, and as part of our BFF programme and transformation, we will look to make sure that we're able to understand how many people are travelling between sites, because most services, and I know I have a slightly different view on this, but most services are provided on both sites. It's some of the inpatient bit that isn't, but we'll put some numbers to that, Liz, and we can talk about that when we meet in due course. I'll let Vicky come back on patient visiting and any exceptions. And the staff awards, yes, they still happen, and Steve presents those on a face-to-face basis, and we have pictures to share, but perhaps it's a valid comment that we might want to put that into an update at the beginning so people are aware of that. And patient stories, Vicky might want to come back, but we do patient stories in our Safety and Quality Committee, but hopefully that's covered everything. I'm going to go to Vicky because she might want to supplement some of that.
Thanks, Jo. Thanks, Liz. I wasn't as organised as Jo and I didn't write them all down, but I think she covered most of them. In terms of access to digital technology, absolutely. And although we have mobile devices and tablets and iPads, we also still use the phone. So, of course, we have done that just this week, actually, because we had a patient who didn't have a smartphone, or I think a member of their family didn't have a smartphone. So there's never a problem in that regard. Appreciate not every patient may be well enough to speak on the phone, but I think staff try as hard as they possibly can to have some kind of dialogue and connection. The question about how restrictive the visiting is, I completely understand that, and it has been one of the most difficult things throughout the whole of the pandemic. Personally, for me, I think to have to restrict that, it's very difficult. The staff find it difficult and at times distressing as well. And I take your point that if somebody has, you know, a pastor or anybody else who wants to come in, then that can be difficult. But ultimately, we have to look at a number of factors. So in a typical bay on a ward in the hospital, we can't have the bay crowded. We're thinking about the ventilation and the space and the number of people in that bay, and and it's about trying to make sure that everybody has a chance to have somebody visit them. But I appreciate that's very difficult. What I would say is, on a glorious day like today, if you can pop outside in a wheelchair, we do that too, and just say to people, we're limited and restricted when you're indoors, but if weather permits, then of course pop outside. If staff can help, you know, and organise wheelchairs and other things, if patients need that, then they do all that they can. But I think be outdoors as much as you can, and then we're not restricted. And then just finally, thank you for your support. I think it is challenging for staff. The vast majority of patients are very supportive and understanding of needing to wear masks and keeping their distance, as are the vast majority of the public. But we do, unfortunately, on occasions have some very challenging conversations. We're not alone in that. I know, speaking to other chief nurse colleagues. So again, our plea is to please understand why we're asking for people to do that, and ultimately it's to keep our patients and our staff safe. So we will challenge people politely and kindly, but and if we feel that it's unsafe, then we may have to ask people to leave, or ask that they don't attend in person. But thank you for your support. Sorry, and a patient story, absolutely. I'm sure Joe and I and others will have a think about that with Amanda as our chair of the quality committee, and we can look to see what we can do.
Thanks. I think I got most of that, but sometimes the connection sort of went a bit fuzzy. And can I just ask, are you meeting in person next time, or is it still on Teams? Teams.
It'll be on Teams,
Yep.
I think, at least until the end of this year. This year. Yeah.
That's a lot easier with travel.
Well, I think actually, Liz, there are some advantages. There are some advantages to doing it this way for people for whom travel would make it inaccessible. But this platform, although it's good if you're on Teams, if you don't have Teams, it's not quite so easy. So I think we're going to keep it under review, but certainly for the next couple of public meetings, I think we'll definitely be in this. We'll definitely be in this format. Steve, did you have your hand up?
Thank you. Hi, Liz. It was just really to add to what Joe said about the recognition. Coincidentally, so we have a Hero of the Month awards, which we do for each area of the trust each month. Coincidentally, the execs look in their inboxes. I think they've actually come out during the meeting for this month. The nominations. Every person that's nominated gets a certificate from the chair and the CEO and recognised, and those winners from each division each month actually get a small gift as well. We're running the Pride of ESHT Awards, which are our annual awards ceremony. We're having to do it slightly differently now, I think for the same reasons we've just talked about, Teams and these meetings. So we're running a number of local award ceremonies this month to recognise some more of our heroes across the organisation. We've also introduced some other forms of recognition, some of them quite immediate. So, for example, we've introduced something which it might sound quite little, but it's actually getting very, very good feedback, which is just thank you cards around the place. Like if someone does something great, you can pick up a card, you can write them a note, you know, say who it's to, write them a note. People very, very much appreciate getting those. So we're looking at different ways to do things in a different environment as well, Liz. So I think it's worthwhile saying it's not just about the heroes, and I think Joe's point is right. It would be good, you know, it'd be good to bring that here, but we're looking at many, many different ways to try and provide very direct recognition to some of our amazing people that do get nominated for doing amazing things. So just wanted to build on that a little bit.
Thank you.
Thanks, Steve. Thanks, Liz. So that's it. Thank you, everybody, for your contribution. Our next meeting will be on the 9th of December at 9:30. Festive jumpers not allowed. Thanks very much. And for those of us involved in the next meeting, see you at 1 o'clock. Thanks, everyone.